We now go on to a different area, completely different area, something very close to our heart, dialysis access. It will be Dr. Atanu Pal who would be telling us about dialysis access problems faced by nephrologists. He's a nephrologist. Well, he's a nephrologist. Well, if you are facing a problem as a nephrologist, your solution lies with vascular surgeons.
Thank you, respected chairperson. At the outset, I should express my gratitude to Dr. Jayanto Das, my mentor since my MBBS days until today, who invited me in this forum. And at that time, I was delighted and rather confused that what should I present when I go through the topics that will be discussed here. So then there was a discussion between Jayantoda and me, and then I found that we face lots of problem in dialysis access. But what is related to you people, that probably is very, very important, because if you consider today's world, it is around 10% is the prevalence of CKD in general population. That means every 10% out of 100, if you look at, they are suffering from CKD by any form. And that is the real world data. And if you look at carefully the urban rural population, their probably data is more. So the days are coming when more and more dialysis access is important, and so we'll face more and more dialysis related problem, particularly the access. And when you consider this dialysis, the access is the Achilles heel, and there we face a severe problem that I mentioned, that around 20% of all hospitalizations related to these dialysis patients are because of the dialysis access, other than the cardiovascular problem, the heart failure, the infections and others. So this is 20% of all dialysis patients are actually admitted because of the dialysis access related problem. So this is really significant. If we consider the different access, then we are having three types grossly. One is temporary, that is the jugular, the femoral. Rarely we do subclavian because of the chance of stenosis is very high and very early. The semi-permanent access is the permanent catheter, well known as palm cath, which is a bridge between the temporary access and the permanent access, that is the AV fistula. When it's problematic to create AV fistula, then we put graft, though AV fistula is the most sustainable for us, the nephrologist. Now, when there is this access, then we definitely face problems. I'm not going in detail all the problem, like the immediate problem that the bleeding, the entry of this access to different structures like your the aorta, like mediastinum, heart, pleura, etc., etc. The most important problem that we face is the infection. When it is a temporary access, the problem is the infection. So that is called catheter-related bloodstream infection. Most of the time, patients actually collapsed or expired because of this infection. This is a dreaded complication. So temporary access is not desirable for our dialysis population. But the problem lies where? Our mentality. I'll come with that. Next is your semi-permanent catheter. There is a permanent cath where you can keep this palm cath from 3 months to even 3 years. So I have my own experience that a child was having palm cath, and we kept that palm cath, or we could maintain that palm cath for 3.5 years. And after transplantation, we could just remove it because no other access was available for that particular 6-year-old child. So this is a very important bridging area, or it could be a savior. But the problem lies here is when it is a long term, then you will have central venous stenosis and the thrombosis. These are two dreaded complications, because when you will put AV fistula, then this central venous stenosis will cause a severe problem in the fistula flow and the fistula function. So this is a very important area where there is a semi-permanent catheter is implanted. You need to change it as early as possible to make it AV fistula. So now coming to the AV fistula complications. So this is the permanent and the gold standard and the longest durable access for the dialysis patients. But here again, you will face lots of problems. Some are because of the related to immediate, that again the bleeding, the thrombosis, the infections, all are because of the immediate complications. But we actually deal with the long-term complications, where this is a very, very important, and that area should be dealt with you people. So the long term is the stenosis and the thrombosis. These two things are very, very common in case of this AV fistula long term use on the dialysis population. So others, the complications are chronic venous congestion because of some, again, because of the stenosis or thrombosis. The steel phenomenon, this is another very important, the peculiar phenomenon that occurs during particularly the dialysis. If there is a steel phenomenon, then the particular site, that the particular limb will be having the less blood supply, so there will be ischemia, and the gangrene may ensue if the steel phenomenon is not considered properly. Then most important for nephrologist is the dialysis inadequacy. When there is a AV fistula malfunction, either because of the thrombosis or because of the stenosis or because of the compression from other sides, the problem is the inadequacy of the dialysis. And if the kidney function is actually replaced by the dialysis, if this dialysis is not properly maintained, then the patient's lifestyle and the quality of life will be hampered. So whatever desired lifestyle that we want to provide to a particular patient, that is not actually acceptable for this particular patient because of the fistula function. So that fistula is probably the heart for a nephrologist for a particular patient. So we need to maintain this AV fistula in its very, very important aspect. Access failure, because of the we having lots of problem, particularly the dialysis technicians, the patient itself, the infections and others, the fistula, most of the time we lost this AV fistula. The pseudoaneurysmal dilatation, this is another long-term complication for AV fistula, which forms after having recurrent your penetration of the puncture, and that is most commonly it is because of the problem with the endothelium lining of the intimal lining of the this venous side as well as the arterial side. And bleeding from the prick side, that is commonly occurs when there is stenosis downstream, and that bleeding usually is more than 20 minutes after. If the bleeding is not stopped from the prick side, we commonly take it as a stenosis downstream in the AV fistula. An infection, again, I'm telling you, this infection is dreaded infection, because the infection is considered here is equivalent to the endocardial infection, that is the endocarditis. So it is equivalent to endocarditis, a dreadful infection that that we deal with in the MBBS days as well as the post-MD days, the MD days, that is a severe infection where the patient could die because of this endocardial infection. So this is very, very important, where if you are facing this infection, the Doppler is the diagnostic modality, where after diagnosing you have to continue the antibiotics till 6 to 8 weeks time, and the blood culture as well as the thrombus, the endocardial thrombus or the infective thrombus is actually vanishes. So this is very important area where we should diagnose this infection. Now, bleeding with infiltration is another very important, because the practical problem. It is particularly occurs because of the technologists or the technicians problem, when the inadequately trained or well-trained technicians usually miss to puncture that particular site of AV fistula. There is bleeding from that particular site, and that is causing AV fistula infiltration. This is another very important as well as very common complication, which ultimately leads to fistula loss, and this is very sad. The way to prevent is that you should be very much careful about the fistula puncture, as well as when it is infiltration occurs. So it have to give rest for at least 24 hours to even 2 weeks till the infiltration goes off. And after that, again, you will do the AV fistula cannulation. And in this period, you need to create on a temporary access to maintain your AV fistula patency. So here I put a few examples of what we actually face in our day-to-day practice. So this is a common example where you can see that this is a person, a 51-year-old male, having dialysis 3 per week with no urine output, and HD vintage is 2.3 years. So for last 2.3 years, patient is on dialysis, and he is having left brachiocephalic fistula for 1 year. And earlier, there is a history of temporary access right internal jugular for 2 times, left internal jugular vein for 1 times, and CRBSI episode for 2 times. That means this is the area where the patient is having temporary access, and after that patient was put this brachiocephalic fistula, and that was maintaining for last 1 year. And now the patient presented with us with the left-sided upper limb and facial swelling that you can see here for the last 3 months. So associated with the increased venous pressure, that venous pressure alarm we usually get from the dialysis machine, and prolonged bleeding after withdrawal of the needle because of the stenosis, that is the indicator that the patient is having downstream stenosis. So what is the diagnosis? That is the clue that patient is having downstream stenosis. So if I can play this. So here we have done this venography, where you can see that there is no flow here. After that, we did this balloon, and after that, you can see that this is this cannulation ultimately is successful. Yes, this is the flow. So this is the area where we are very much lacking in, particularly the government setup. This is very rarely available. So after a long fight of around 3 to 4 years, we ultimately successful and have our cath lab that is also run by a radiology department, and we usually go there for 2 to thrice a week with again intra species fight between the radiologist, the neurologist, and the nephrologist, and ultimately we could get the time as well as access for doing these particular procedures, but we are doing in our SSKM hospital. So this is after this procedure. Now you can see this total swelling of the patients are actually gone. The patient is now having normal shape of the face as well as the upper limb. So another case, this is a patient 65 years old male, CKD 5D, residual renal function is 100 ml, that is the urine output of 100 ml, MHD 3 per week, 3 years, 3 months is the HD vintage, and access is left radiocapular fistula. So he presented with us with the 2 AV fistula failure for for the last 3 weeks, and there is also a history of primary AV fistula failure earlier. That means the patient is having recurrent AV fistula failure. So what could be the next step? So again, we did the clinical examination, that the arm elevation test followed by the clinical, that is the Doppler flow. Then we did the diagnostic fistulography and fistuloplasty. So this is again where you can see that here you can see that there is no flow in the AV fistula. After plasty, you can see that there is flow in that particular AV fistula. Yes, this is the area. Earlier there is no flow in this particular AV fistula site. After this fistuloplasty, we have this AV fistula working, and then patency is maintained or restored. So this is actually our algorithm, what we follow: fistula related issue, AV fistula Doppler, fistulography, then the fistuloplasty. Actually we are trying in our center with the limited capacity, with the limited experience. We are actually getting help from the interventional radiologist. So this is our brief data since 2021 January to December 2022. Central venoplasty performed 43. Successful recannulation was 37, that is 83% was the successful recannulation. And stent we have placed in 2 cases, restenosis in 24% of patients. So it is not that high in our center, though we are inexperienced. Time to develop restenosis was around 88.64 days. So the important factor is again for this AV fistula failure or stenosis is the HD vintage. That means the longer duration of the HD vintage and the type of central venous stenosis. These 2 are the most important factor that we saw in our population that are giving rise to successful AV fistula, means your AV fistula fistuloplasty outcome. Another important factor where this occurs, we found, is that CRBSI, that is the more the number of infections, more the chances of stenosis and the fistula dysfunction, and the comorbidities, particularly out of them is the hypertension, dyslipidemia, diabetes, and ischemic heart disease. This, if are associated, then we are getting more and more number of fistula dysfunction. So the important factor for the central venous stenosis are improper tip position of the previous temporary axis. Either it is jugular or it is a palm cath, that is a semi-permanent axis. The dialysis vintage, the duration of dialysis vintage through that particular temporary or the semi-permanent axis, number of temporary axis created because of the recurrent failure. So the duration of the temporary axis in that particular patient, CRBSI, that means the infection episodes, the comorbidity that I mentioned, there is a diabetes, hypertension, ischemic heart disease, dyslipidemia, or the problem, failure of recannulation, the very late presentation from the symptom onset. That is, if the epifistula malfunction is presented late, then we found that the chance of getting restenosis is very common, and problem with the cannulation. High degree of chronicity and multiple collaterals are the problem where this successful recanalization is problematic. Fistuloplasty, again, total procedure performed 77, mean epifistula patency 1.3 years, 0.3 years, successful recanalization 70, rather 94.8% patients who has a successful recanalization. Failed is only 5.2%. Here for epifistula, the important factors that we found is the presence of long segment narrowing. So when there is a long segment narrowing with the multiple collaterals, then it's very difficult, and these 4 patients are having this presence of long segment narrowing with multiple collaterals because of number 1, longer dialysis vintage, and number 2, the previous recurrent temporary axis use. Improper evaluation by the Doppler before creation. So now in our protocol, what we are doing after the clinical examination, whether the particular limb is suitable for epifistula creation or not, we are actually doing the ultrasonography Doppler study to find the proper axis, that is the proper vein as well as the proper artery and the proper site in that particular limb. And so we are getting more and more number of successful epifistula continuation for long term. Side-to-side anastomosis is another factor where this epifistula problem occurs. Deep venous communication is another area. You need to keep the 6 millimeter of depth, venous depth from the surface. That is the ideal. If it is more, then the chance of getting this epifistula problem will be there. Technique buttonhole versus rope ladder. This is nothing to deal with this here. It is because of it is the process of epifistula puncture. Either it is the buttonhole or is the rope ladder. We have seen that if the rope ladder pattern of epifistula puncture is there, then the chance of stenosis is less. And if the patient is having central venous stenosis, then the chance of getting epifistula malfunction is obviously there. So this is epifistula stenosis according to the site and outcome. I am not going in detail. In radiocephalic, we got the maximum number of epifistula stenosis, that is 62%. This is the procedural complication. So bleeding is the commonest problem. Arterial thrombosis is less, then pseudoaneurysm and venous rupture.
Sir, you have to wind up,
yes,
please.
Sir, I'm done, sir. So for this reason, for this particular area of concern where nephrologist has got a very less motivated as well as less expertise, we are conceptualize a team where there will be vascular surgeon, there should be primary care physician, radiologist, dialysis staff, dedicated coordinator, and ultimately the patient. All ultimately will form a team, and that will form a successful vascular team for the epifistula creation as well as the vascular access maintenance. And nephrologist will definitely a team leader, but the key player will be again you people. So we need more and more help from you people so that we should maintain a good epifistula for a long term and good quality life of a dialysis patient. So more or less that's all. That we need a combined team approach to have a good quality of life for a particular dialysis patient. There's a longer life with a good quality of life, with good AV fistula, with probably 3 per week hemodialysis without any complication, hospitalization, and less expenditure from the patient's perspective, as well as the in concern the government hospital set up the more number of expenditure because of this restenosis or thrombosis, cannulation, and others. Thank you for patient hearing.
Thank you very much, Dr. Pal. That was a very illuminating lecture. Just one humble suggestion. Since you're doing all this work, I'm sure you have seen a pair of scissors. Please use a pair of scissors and cut one part out of that slide.
Yes, sir.
No radiologist, vascular and endovascular surgeons.
Sir,
So please come and join us. Bellevue will not give you anything. We are doing the entire gamut of vascular access. Basilic vein transposition, a very underutilized operation.
Yes, sir.
In our Dr. Shubhabrata Banerjee and Jayanti is regularly doing fistuloplasty, central veins. So please come and join us. Thank you.
sir.
The session comes to a close. I think there was a question from Professor Shukumar Maiti. We just take that and we'll move on to the next session.
Wonderful presentation, and you have said about the thrombolysis with the help of catheter. So what are the indication of those cases? If it is a big thrombus, whether the catheterization may cause the breakage of the thrombus, and which was stable within the vein, can it cause embolism?
Sir, we have a session on that. Dr. Rahul Jindal will be talking on that.
Okay, thank you. And the movement of the catheter, whether it will be towards the vein, the heart, or away from the heart, because of the presence of the valve.
Your question is very right.